Hey everyone, welcome back to Izzy Medicine, where we take those hormone pathways that make your brain hurt and give them a little bit of IV hydration and clarity. Or maybe it's not the pathways, but us that need IV hydration after we're done studying. So today we're going to dive into two disorders that are all about water balance. And we're going to talk about diabetes insipidus and SIADH. They are two completely opposite problems, but they're tied together by one hormone, ADH, antidiuretic hormone. So let's talk about a potential patient. Let's say you're on the floor and the patient comes in with massive polyuria. We're talking liters of urine day after day, and they're constantly thirsty. So your first thought would be, well, they have diabetes. So you check their blood sugar, but their blood glucose is completely normal. What's happening? Why are they peeing and thirsty, but don't have hyperglycemia? This is where ADH, antidiuretic hormone, takes the center stage. Ta-da! And this is the thing. ADH is all about water and not sugar, not insulin. Just good old-fashioned water retention. So as per usual, let's talk about what ADH normally does before we go into what it does when it wreaks havoc. ADH is released by the posterior pituitary, but as we learned in our pituitary disorder lectures, it actually is made in the hypothalamus, and when it shows up at the kidneys, what it does is it knocks on the door of the V2 receptors in the collecting ducts. So those receptors, when the ADH knocks, they respond by opening water channels called aquaporins, and they let water back into the bloodstream, and that's the loop. So if the body needs to hang on to water, maybe because you're dehydrated or bleeding, ADH is the guy. So ADH, out of the posterior pituitary, knock, knock, knock on the kidneys, V2 receptors. V2 receptors respond by opening water channels called aquaporins, and water goes into the bloodstream. That's kind of the situation that when it acts normally. But what happens when things go wrong? Either we have not enough ADH or the kidneys stop responding to it. And that's diabetes insipidus. Or you make too much ADH, and that's SIADH. So let's start with talking about diabetes insipidus. There are two main flavors, yummy yum. There's central DI, where the pituitary or hypothalamus just isn't releasing enough ADH. And then, as we said, there's the nephrogenic DI, where the ADH is released, but it's not working at the level of the kidneys, and the kidneys are basically ghosting it. Let's zoom in on central diabetes insipidus to understand it a little more. What's the core problem here? It's that the posterior pituitary isn't releasing enough ADH. And that's usually because the pituitary itself, or the hypothalamus above it, has been injured or damaged. Of course, this can happen in several ways, so let's talk about that. Maybe there's trauma. Maybe there was head injury, and this disrupts the connection between the hypothalamus and pituitary, and what was supposed to be produced in the hypothalamus and get released by the pituitary isn't. So now we don't have enough. Or maybe our patient had neurosurgery. Maybe they had transsphenoidal resection to remove a pituitary tumor, and during this process, the posterior pituitary got taken out. And that's where ADH was being released from. So now we don't have ADH released because the portion that was supposed to be doing that is gone. Another cause that we've talked about multiple times in multiple lectures is Sheehan syndrome. And what can happen here is after a woman gives birth, she might have a massive postpartum hemorrhage. This postpartum hemorrhage lowers blood volume to the whole entire body, and the pituitary gland is super sensitive to drops in blood flow, especially when it's enlarged during pregnancy. And when there's severe blood loss, like after childbirth, the reduced perfusion can cause basically ischemia and necrosis, and the pituitary just dies off. And if the posterior pituitary that goes down, so does your ADH release. So basically, regardless of the cause, whether it's trauma, surgery, hemorrhage, infarction, the end result is the same. There's not enough ADH being released, and that means that there's not a product, so to say, to go to signal the V2 receptors in the collecting ducts that are in the kidneys. And because the V2 receptors are not getting signaled, there are no aquaporins that are opening channels and allowing fluids to go back into reabsorption. So water just gets peed out, flows right out like a faucet. And the result is polyuria. Lots and lots and lots and lots and lots of dilute urine. And what happens is because the body's losing so much urine, the sodium climbs, and that's hypernatremia, just by way of concentration gradients. Finally, because there's so much volume loss, the body senses the dehydration. The patient is getting dehydrated, and the thirst mechanism kicks in. So this is where the patient becomes polydipsic. They're drinking water like it's their new full-time job. They're just thirsty, drinking, peeing, drinking, peeing, drinking, peeing. So that's our central diabetes insipidus. What happens in nephrogenic diabetes insipidus? So what's happening here this time, ADH is being made and released just fine. The hypothalamus is fine, the posterior pituitary is fine, and they're doing their jobs. The hormone is circulating and it's arriving at the kidney's door, but the kidneys, they're like, no, we don't want you. We don't know what to do with you. They're ignoring it. That's because here, the V2 receptors on the collecting ducts aren't responding. It's basically like the doorbell's ringing, but nobody's home. What can cause this? So the one big one, especially we have to think about bipolar patients, is lithium. Basically, lithium messes with the kidney's response to ADH, and it makes it harder to activate aquaporins. Another one is hypokalemia, because low potassium makes the tubules less responsive to ADH. And hypercalcemia, too much calcium, dulls the kidney sensitivity to ADH. And there are multiple conditions. For example, we can have a patient with hyperparathyroidism that has excessive calcium. We can have hypokalemia from diuretics, and that can cause the kidneys not to respond to ADH appropriately. So in all of these cases, ADH is present, but the kidneys just don't listen. So water just keeps pouring out. So again, there's no aquaporins because there's no response in the kidneys, no water reabsorption, water loss in the urine. And then again, we have the same thing, polyuria and hypernatremia, just like in central diabetes insipidus. So the bottom line, both of these types of diabetes insipidus, the end result is the same. Tons of dilute urine, the rising serum sodium situation because it's just by way of concentration gradients. When there's all the water's coming out, there's too much sodium left. And the patient is guzzling water like their life depends on it, because it kind of does, because hypernatremia is a serious situation, so is dehydration. Now that we've covered diabetes insipidus, the central and the nephrogenic, let's flip the script. Now we delve into SIADH, and this is syndrome of inappropriate antidiuretic hormone. And here we got the opposite problem. It's too much ADH. That excess ADH is telling the kidneys to hang on to water, even when the body doesn't need it. There are a few big reasons that this can happen. So firstly, the posterior pituitary can over-release ADH, and it can be due to things like stroke, brain trauma, infections, or any process that can affect the hypothalamus or brainstem. Another common trigger is hypoxia. So low oxygen levels from things like pneumonia, COPD, mechanical ventilation. They can stress the body and they can stimulate ADH release, even though the volume is normal. It's a little bit weird because there are receptors in the carotid artery that sense oxygenation. When the oxygenation drops, the body's response is to think that maybe there's low volume and ADH is released in response, even weirdly enough when the volume is normal. Certain medications can also increase ADH release or enhance the effect. So SSRIs, carbamazepine, tricyclic antidepressants, these drugs can either stimulate ADH release or they make the kidneys more sensitive to it. So in essence, ADH becomes more active. Lastly, there's ectopic production of ADH, and we know that there are a lot of ectopic hormone-producing tumors, and in this case is famously done by small cell lung cancer, and it starts pumping out ADH from tumor cells, and they're not supposed to be doing it, but they're doing it anyway. And we've learned this in several lectures, that small cell lung cancer can sometimes produce different hormones unnecessarily. So what happens with all this ADH floating around? The kidneys go into overdrive, reabsorbing water. All those channels that we discussed, the V2 channels and the aquaporins, are, instead of being non-responsive and underactive, they're overactive. So the body reabsorbs water in excess amounts, and the blood becomes very, very diluted. And because of this dilution, sodium starts dropping by way of dilution, and we get hyponatremia. Because we're pulling all this water into the blood and holding on to it, the urine stays concentrated. And what can happen is this kind of can sneak up on our patients. Maybe at first they're not symptomatic, but then the sodium drops too fast and too low. And that's when things can get dangerous, especially if the sodium is under 120. How so? Let's explain. The patient can get cerebral edema, and the mechanism is that when serum sodium drops too low, the blood becomes hypotonic compared to intracellular fluid. So there's basically a lot more fluid outside of the cells than there is in the cells. So water moves outside of the cells from the extracellular space into brain cells to balance this osmolarity. And because of this fluid influx, the brain cells start swelling with water, and that increases intracranial pressure and causes cerebral swelling. As the brain swells, we then can develop seizures because the pressure that is altered and sodium levels themselves dropping, they disrupt normal electrical signaling in neurons, and it lowers the seizure threshold significantly. So we can have a patient develop cerebral edema and seizures. And lastly, the more dangerous, not that all of the other ones are not dangerous, a patient can develop brain herniation, because if swelling continues unchecked and the pressure, intracranial pressure, rises and rises, there's nowhere to go for the brain tissue because we have a skull. And what can happen is the skull can force brain tissue to shift or herniate through rigid spaces like the foramen magnum, and that's life-threatening. That's brain herniation that can lead to death. But here's the twist. We can't fix that sodium too quickly because what can happen is we risk something called osmotic demyelination syndrome. And this is the mechanism here. When you rapidly raise sodium levels now, you basically suddenly make the blood hypertonic now compared to brain cells. And now water can rush out of all those neurons and the cells shrink quickly, and it damages the protective myelin sheath, areas like the pons especially. And this can lead to severe and sometimes permanent neurologic deficits, including a locked-in state. So when we replace sodium, we have to be very, very careful, not just with what we treat, but how fast we treat it. So now that we delved into treatment, let's talk about diagnosis and treatment. How do we diagnose diabetes insipidus? If a patient presents with polyuria, usually more than 3 liters a day, like I said, it's lots and lots and lots and lots of dilute urine, and they have polydipsia and maybe signs of dehydration and their sodium levels are up, that's kind of what we base it on. If we see elevated serum sodium, we check that. We check serum osmolality, which is high because all the water is flowing out through the urine. And urine osmolality is low because we have so much dilute urine. What do? How do we test for diabetes insipidus? Is we do the water deprivation test. What we do is we start by restricting water and we see if the kidneys can concentrate urine on their own. Normally, in normal physiology, low water intake triggers antidiuretic hormone release, which makes the urine more concentrated. If the urine stays dilute, it tells us basically that something is wrong with ADH signaling, whether we're not producing it or they're not signaling to the kidneys properly, or the kidneys are not responding properly, so to say. So what we do is we give desmopressin. It's a synthetic form of ADH, and we watch what happens to the urine osmolality. If urine osmolality increases significantly after desmopressin, that means the kidneys can respond. They just weren't getting enough ADH, and that's how we diagnose central diabetes insipidus. If urine osmolality stays low, even after desmopressin, that means that the kidneys aren't responding to ADH. So we gave synthetic ADH, but the receptors aren't doing their job, and that's nephrogenic diabetes insipidus. For SIADH, as we discussed, the patient usually has low sodium, hyponatremia, low serum osmolality, because the water is flowing into the serum, into our blood, and it's so dilute, and high urine osmolality, because all the water is getting reabsorbed from the urine, and we have very concentrated urine. So SIADH is a diagnosis of exclusion because it can mimic things. So what we have to exclude are a couple of things before we diagnose SIADH. We have to rule out hypothyroidism because low thyroid hormone levels can reduce cardiac output, and they can reduce glomerular filtration, and they can trigger ADH release and water retention, and this can mimic SIADH, and this can cause hyponatremia with normal volume. Adrenal insufficiency is another one. So without enough cortisol, ADH secretion increases as part of the stress response, and lack of aldosterone leads to sodium loss as well. So we have low sodium, and volume status can resemble SIADH. Lastly, volume depletion is something we need to worry about that can mimic SIADH, because when the body senses low blood volume from dehydration, diarrhea, diuretics, it naturally ramps up ADH to conserve water. So hyponatremia from volume loss can look just like SIADH, but the treatment is absolutely different. So those are things that we need to work through in the process and make sure that we're ruling out. So before calling it SIADH, we always check thyroid function, cortisol level, and we assess the patient's true volume status. Once those are ruled out and the patient is euvolemic with low sodium in the serum and high urine sodium and osmolality, that's SIADH. Now that we know how to diagnose, let's delve into treatment. For central diabetes insipidus, it's easy. We know that in central diabetes insipidus we're missing ADH, so we give the synthetic desmopressin. We monitor sodium to avoid hyponatremia from overtreatment. For nephrogenic diabetes insipidus, as we learned, giving desmopressin doesn't help because the kidneys are not responding to natural or synthetic ADH. So we have to fix the cause. We look whether we need to stop lithium, whether we need to correct calcium or potassium to make the kidneys respond better. We can also add a low sodium diet and see how our patient responds. For SIADH, the first line treatment is fluid restriction. So we restrict the fluids typically to less than a liter a day. And if that's not enough, we give salt tablets and loop diuretics. So we remove water and we retain sodium. If the patient is symptomatic, if our patient is in seizures, confusion, or the sodium is under 120, we need to act fast. But as I said, we have to act, but we have to act carefully to prevent osmotic demyelination syndrome. So we raise sodium slowly with 3% hypertonic saline, and we monitor very closely, and we give no more than 6 to 8 milliequivalents per liter in 24 hours. And so we don't get that dreaded complication of demyelination syndrome. So this is it. We wrapped up our diabetes insipidus and SIADH lecture. I hope you had fun having a deep dive into these ADH disorders. I hope that it was fun, entertaining, helped you clear the fog, and I hope to see you in the next lecture. If you enjoyed it, hit like, leave a comment so I can answer any questions. Subscribe for more fun Izzy Medicine breakdowns. And until next time, stay curious, stay kind, and see you later. Bye.